Hi everyone, this is Chintan Rupareliya. I'm a vascular neurologist and neurointerventional fellow at Oxnard Medical Center in New Orleans, Louisiana. Today, I will be talking about uses and pitfalls of CT perfusion in this time of modern mechanical thrombectomy. As we all know, time is brain during acute stroke. So in the setting of stroke in the emergency department, accurate imaging of cerebrovascular diseases, in particular ischemic stroke, is of crucial importance. Stroke and neurointerventional communities have historically relied heavily upon strong decision-making based on the data. In 2015, 5 major trials demonstrated superiority and safety of mechanical thrombectomy in the treatment of acute ischemic stroke, and 2 out of these 5 trials used CT perfusion in addition to clinical criteria to see which patients qualifies for mechanical thrombectomy. And since then, in addition to non-contrast head CT scan, CT angiography, and also CT perfusion, or most of the time, the combination of both, are commonly used imaging modalities in the setting of acute stroke. During mechanical thrombectomy, CT perfusion helps identify salvageable brain tissue, guiding the treatment decisions. Diffuse 3 and DAWN trials use CT perfusion and MRI diffusion-weighted imaging sequence in addition to standard inclusion criteria to determine patients' eligibility for mechanical thrombectomy, and both of these trials provided convincing evidence of benefits of thrombectomy in the anterior circulation large vessel occlusion. This further helped validate the use of CT perfusion as part of commonly used workup in the acute ischemic stroke in the patients in the emergency department. So, what is CT perfusion? CT perfusion is particularly useful in the late presentations, where traditional imaging may not provide adequate information. Main goal is to obtain the qualitative and quantitative evaluation of cerebral perfusion and to differentiate ischemic core from the ischemic penumbra. It is performed by intravenous injection of 40 cc of contrast, followed by rapid sequential acquisition of images, and CT perfusion assesses the blood perfusion at the capillary level. 4 major parameters are mathematically calculated: cerebral blood flow, which is the total volume of blood moving through the part of brain in certain amount of time; cerebral blood volume, which is the total volume of blood within the given amount of brain tissue; mean transit time, average time of blood to circulate through the specific brain tissue and is measured in seconds; time to peak, or Tmax, which is time at which the contrast concentration reaches its maximum attenuation. These 4 parameters are used to identify the ischemic core, which is part of ischemic brain that is already infarcted or destined to infarct regardless of therapy. It is defined as prolonged mean transit time, decreased blood flow, and also the decreased blood volume; and penumbra, which is also known as tissue at risk, which is an area of brain that is salvageable if timely intervention is provided. It is defined as area with prolonged mean transit time, decreased the cerebral blood flow, but near normal or increased cerebral blood volume, also known as the mismatch. Mismatch happens due to autoregulatory vasodilation and collateralization from the surrounding areas in attempt to maintain the perfusion. Takeaway point: higher the mismatch, bigger is the penumbra, which translates into higher likelihood of restricting the infarct growth with timely intervention. So what are some of the pitfalls of CT perfusion? Artifacts, motion artifacts, beam hardening, and metal artifacts can affect the accuracy of perfusion measurements, leading to misinterpretation. Contrast administration, adequate dosing, or mistimed acquisition can impact the quality of perfusion data. Patient factors and concomitant conditions, especially patients with poor cardiac output, seizure, or severe proximal arterial stenosis, can lead to inaccurate perfusion maps and erroneous diagnosis of extensive ischemia or global hypoperfusion. Post-infarct core. In approximately 10% of patients, CT perfusion may overestimate the infarct core on admission by predicting the lesion in the area that will later not show as an infarct on the follow-up imaging. Especially, this happens in the early time window. Pseudonormalization of core, which is a false normalization of core due to slow progressing infarct or patients with fast collateralization and contrast staining. It is usually overcome by performing perfusion scans shortly after the CT angiogram. Next is limited utility for posterior circulation infarcts and small infarcts. The current CT perfusion protocols are centered upon the basal ganglia and supraganglionic levels. This, in addition to beam hardening from the temporal bone, makes it limited to utilize for the posterior fossa infarcts. And last but not the least, availability in the low resource setting. Centers with the limited resources may not be able to facilitate CT perfusion, forcing decision-making on limited imaging, or the clinical scenarios adding the burden on the comprehensive stroke centers. In recent meta-analysis of the 6 randomized controlled trials, we all found that the patients with the larger infarct core treated with thrombectomy achieved better functional outcomes compared to medical management alone. While it is still a question about utility of CT perfusion at different centers, hopefully further research and data will simplify the imaging choices. Thank you.